Good afternoon, everybody. I want to start I think we should remind ourselves that all the global societies last year agreed to a non-stigmatizing terminology around alcohol. So I think we should continue to use alcohol-related liver disease, alcohol-related hepatitis to avoid the stigma around it. But otherwise, I shortened my title a little bit to here, therapies and approaches for managing alcohol-related liver disease. So I think that nails it down. It also means that I will not talk about alcohol-related hepatitis. We just had a very beautiful overview of that, so that's not needed. But rather the bigger chunk of patients that are captured in the new nomenclature of steatotic liver disease. And that's basically this span. The span from actually the part, even in INASL-D, that drinks 2 units for females and 3 for males, that actually has an impact. But indeed also in the intermediary group and in the group to the right, that we with high alcohol consumption. So that's what I want to discuss, but also in particular around treatment for mid-ALD and ALD, where we currently have no treatment, but where things are emerging to happen, and there's a huge unmet need, as we heard in the first talk by Dr. Shah, that this is the leading cause of liver-related morbidity and mortality around the world. What I want to start with is trying to understand, which is also emphasized in the new nomenclature. You know, the starting point is steatosis and at least one cardiometabolic risk factor. So therefore, we need to understand what is the combined role, and even more than that, the interaction of alcohol and genes. We heard a lot about the genes. I'll only discuss that minor, but it's really important with the genes and cardiovascular risk factors, because these goes together and has important implications for how we manage the patient, how we develop drugs, and how we actually see and understand the disease. So this is already a very old study, but here you can see on the x-axis what is the risk of liver-related risk of cirrhosis if you're a baseline versus high BMI above 30 or have high alcohol consumption. You can see 1.3, 3.6, but if you have both high BMI and alcohol, suddenly you go to almost 10. And that's the interaction factor, and that's what we need to understand in this setting. 1 + 1 is not 2, 1 + 1 is 4. And again, emphasizing the need for targeting both of these things in this patient group. Since that, we've learned a lot about the genes. We heard about it before. I just want to re-emphasize here. This is only the PNPLA3. You can advance it more with polygenic risk scores. But this one captured the 10-year rate of cirrhosis. To the bottom, you don't have excessive drinking, no obesity, no carriers PNPLA3, very low risk. Then you can mix the different risk factors here. The more you add, the higher you come. And you both have drinking, obesity, and muscle for PNPLA3, you have almost 7% 10-year risk of cirrhosis. Again, the same point that all these factors goes together, and we need to understand them together. But what does it mean? What is the risk? So the nomenclature is 1 year old, and they were not actually evidence-based. That was consensus-based. So we set up to do a validation. How is this actually applicable? And this study was published half a year ago in Lancet Gas-Hep. We had a large chunk of patients we were able to categorize in whether they had no SLD, MASLD, mid-ALD, or ALD. And this is then the time without hepatic decompensation. Point learning number 1, it was quite easy to map them into this, steatosis, risk factors, and alcohol category, and then we followed them up. And you can see there's a progressive increasing risk of decompensation the more alcohol you add, so alcohol denotes a more aggressive phenotype. And that was translated also into an increased risk. This is survival, and again, same pattern. So telling us that, okay, same family, but this is actually the one with the worst prognosis, and thereby also massive unmet need. Another important thing I think we learned in this study, which I think we probably ignored for quite a while in alcohol-related liver disease, is associations with cardiometabolic risk factors. Again, same study. If we just take here to the left, that's the patients without SLD and those with SLD. Take the group with SLD. This is the proportion with 0, 1, 2, 3, or 4 cardiometabolic risk factors. So from this is 4 or 5 cardiometabolic risk factors. You can see that 45% have 4 or 5 cardiometabolic risk factors. That's massive. 45% of 5 cardiometabolic risk factors, that's massive. And then if we look to how many had no cardiometabolic risk factors, 98% had at least one cardiometabolic risk factor. So these patients are cardiometabolic sick. If we then make the breakdown into the different categories, MASLD, med-ALD, and ALD, you can see the same pattern. A bit more in MASLD, a bit less in ALD, but not much. So the ALD also, 45% had 4 or more cardiovascular risk factors. You have that, you have metabolic syndrome, you're high cardiovascular risk. And as you can see here, if you had those had alcohol overconsumption alone and no cardiometabolic risk factor, very small group. So that made us again think and trying to put a concept together. How should we understand these diseases? Okay, we got a spectrum here, MASLD, med-ALD, ALD, more alcohol over here. And then we can see the severity of disease here in fibrosis stages. So this was actually to put all the data together on cardiovascular risk in these patients versus liver-related risk. If you take the lower corner, so this is a matrix, lower corner, just take this one here, MASLD, low fibrosis degrade. There's a 10 times higher risk of cardiovascular events down here. Okay, if you go to the right, more alcohol, more fibrosis, 10 times higher liver-related risk. That's important, yet the cardiovascular risk is still non-neglectable and should also be taken into account. Then we can try to understand what are the disease drivers. I'm working my way up to what we should treat and how we should treat. We got the genes, we discussed those, we got the socioeconomic factors, difficult to deal with, but again, back to preventive hepatopathology, this should be taken into account. All these things we can actually already treat. Alcohol more difficult, but we also have measures to do that. So this is sort of the risk modifying interventions we can apply. Lipid lowering statins, no problem, just do it. Antihypertensives already there, cheap, available. Diabetes, also drugs. Weight loss, yes, and we even got drugs coming up. Alcohol cessation. So that's sort of the framework I think we should use in understanding these patients and see it as a metabolic disease. Let me discuss a little bit, because there's no available drug, what's on the approach. And I want to first put the framework, how should we see the disease? I think we can see them again as a spectrum here, and in how much fibrosis they have, no fibrosis, and then you can have F2 or 3 here, or cirrhosis, or you can use the Baveno term, compensated advanced chronic liver disease, and then all the way up to clinical significant portal hypertension, and the approach is a little bit different. So alcohol cessation at all stages, cardiometabolic risk factors should also be approached at all stages, and of course fibrosis when you have fibrosis from significant F2 and up, and also have things that target the vascular component and dynamic component when you have portal hypertension. But also denotes the earlier you get, the higher proportion of reversibility. Okay, what can we actually then target? There are a bunch of things we can target. We can target steatosis, but probably not so important. Cardiometabolic risk factors, yes, we know these. Inflammation, fibrosis, we got a bunch of drugs we can steal or learn from the mass field. We got a bunch of drugs that attacks inflammation, and also with FGF21s with fibrosis. Genes, there are SI silencing RNAs worked, and there's work that can work on both HSD17B13 and PNPLA3. Behavioral factors, I'll come back to that, because that goes to the GLP-1s and FGFs that also work in the brain. But I want to show you 2 studies that targets the gut-liver axis. We heard also in the previous talk how important that is to understand the disease, and we had a few big Horizon 2020 consortia where we worked on that. This is one of the studies we published last year in Lancet Gashep. So trying to use rifaximin to intercept this gut-liver axis as a driver of disease. So we had 136 patients with fibrosis and randomized them to rifaximin. Then we followed them for 18 months, and then did another biopsy. They were distributed like this. The majority is F2, F3 fibrosis, 60 years, alcohol consumption of 50 gram a day, so that would per day put them in the ALD group. Average liver stiffness 8.6, but matching fibrosis. And in the end, after 18 months, we liver rebiopsy 180 patients. So the primary endpoint is this one. So we basically failed the primary endpoint, but that was also very optimistic. That was a 2-stage minor fibrosis store regression. So that was not. But when we look into progression, we could see that in the intervention group, 24 progressed in fibrosis group versus 33. So there seems to be some kind of of halting of disease progression, but also reflecting in less hepatic lobular inflammation. This was partly also reflecting in an overall tendency to less lower activity in various non-invasive tests. Another study we done, it's not published yet, it's on the way, was a postbiotic and attacking the microbiome. This is a postbiotic oat fermented product, but Lactobacillus plantarum 290-90V, micrometabolites and fibers. It's already been tested in ulcerative colitis and also improved gut barrier function. This is a pilot study, 52 patients, 24 weeks randomized throttle index biopsy. We included patients with CACLD, so a transient elastography about 15 without decompensation, then randomized to this product versus a standard diet product, and rebiopsy 6 months later. What we used as the primary endpoints, and this was a phase 2 study, what alpha SMA. Alpha SMA is a readout of activation of hepatic stellate cells and fibrogenesis. It didn't meet the primary endpoint of a 10% reduction, but again, you can see some pattern here. Yes, there was twice as high a response rate in the ReFirm group as the other group. And if we look then in the percentage changed, it was a statistically significant effect, yet the primary endpoint failed. And this was then reflected also by a significant lower ProC3 level, which is a dynamic marker of collagen 3 formation. Then I want to talk a little about GLP-1s. They seem to be able to solve all our problems. I will not talk about that, but there are actually something in alcohol which is very interesting. There are animal studies that suggest that it also affects the brain, it affects the craving, it reduces alcohol, and there are these two and more observational study coming that this associates to a stronger decrease in alcohol craving and fall back to alcohol use disorder. So that means we can see that, okay, GLP-1 can do a lot of stuff, but it can actually potentially also reduce alcohol consumption, and that would put it as a quite attractive drugs for this patient group because they also have the cardiometabolic risk factors. That has actually led Novo Nordisk company to launch a trial, phase 2 trial, 240 patients across 80 sites in the world. The first patient already recruited. Combining these drugs, this is their FGF21 analog, this is amylin, also effect on appetite, and then semaglutide, and various combinations of these to see how that will impact. So we'll look very much forward to see how that actually unfolds. It could be an opening. Again, when these big companies do that, others would follow, and I think GSK is also very close to launching a study on their drugs. A little bit about current best practice. I don't have much time today, but any reduction at any time point is important. What drugs do we have? I think I will only mention 3. Don't use disulfiram, that could be liver toxic. Naltrexone can be used. We use a lot of acamprosate, and that is renally excreted, and it's actually quite easy to handle. Behavioral modalities, I think we should all do that. You should teach all your young fellows, and if you should be able to do it self. What is called screening, brief intervention, and referral to treatment. We need to be able to do an interview, to do an audit, and if we cannot handle it ourselves, refer to somebody who can. That is super simple, and it works. So a final sum up how I think we should do today. So we want to discuss how we end up in these categories. We start up here with steatosis, and the risk factor when we discuss this is alcohol, so we already have suspected SLD. They go down here to the cardiometabolic risk factors. Already said that 98% of them will have it. So you pretty quickly need to consider the level of fibrosis. So if FIB4 below 3, we suggest that is a low risk, then they don't need to be seen by hepatology. If it's a higher risk, then they should be, then you can categorize them into these different categories. And when you then know they have med-ALD or ALD, you manage their cardiometabolic risk factors one by one, ignoring none. Do this with interview, behavioral modality, relapse prevention medications, and then of course the secondary fibrosis testing, whether that be transient elastography, liver biopsy, ELF, it doesn't matter, but just following these patients. Before I end, I've been allowed to use just 2 minutes to invite you all to some of the events that EASL is doing. So first, I would like to invite you to join the INASL community. We discussed that for a long time, and INASL wants to make it attractive for people from India to be part of INASL. I paid 250 euro. If you come from India, you pay 25 euros a year. If you're a student or undergrad student, it's for free. But I think you should really consider this. You get all the benefits. You get a big discount for joining also our annual meeting. So if you don't know it, then go in and sign up and get the benefits for 25 euros a year. Also now we're discussing steatotic liver disease. I want to invite you also to join our meeting in January 23rd, 5th in Estoril in Portugal, where we'll have 3 days. We will have consensus around trajectories. We will have an endpoint around mid-ALD and ALD, and then 2 days meeting with update, both clinical and scientific update in that space. If you're more into liver cancer, we got the IASL Liver Cancer Summit in Paris, in France, in February also. But I'd love to see all of you at our flagship meeting in Amsterdam, IASL Congress, and join 8,000–9,000 people there, and I'm sure we can offer you. If you cannot go there, then do it online, and if you're a member, it costs you very little. But if you don't want to do anything, you can get this for free. So IASL make the best guidelines in the world. We make a lot of effort to make that happen. And now we got this, just let the tone. Now we made an app. So I suggest you all download the app and have your fellows, etc., doing it. Then you can have access to the guideline. And now the new updated app makes it very easy to use and understand. And then you will have at least how IASL interpret the literature across many fields. So please distribute that. It's freely available. You can download, you can use. We're just happy. We make a massive work to do it now. We just want as many people in the world because then it benefits as many patients as possible. Otherwise, I just want to thank you for your attention. This is my research group in Odense in Denmark.